Now we move to our next presentation, which is our second plenary session. Um, for us to start the second plenary session, I now invite pharmacist Ivan IT Jallo to introduce our next speaker. After our next speaker, we will now move to Q&A. Please, Fam Ivan, if you're here, please unmute yourself and then introduce the next speaker accordingly. Thank you.
Thank you so much. Let me just make sure that our next speaker is on the call now. And I need to be sure that he's on the call. Okay, yes, he's on the call. And
Certificate.
then so our next speaker is a medical doctor and is someone that has been actively involved in antimicrobial stewardship, and not only that, health system building. So our next speaker is called Dr. Ibrahim Franklyn Kamara. He's a Sierra Leonean medical doctor. He's a public health specialist. He's also a research scientist. Excuse me, do not disturb. Let me just. He's a research scientist and also a global health leader with extensive experience in clinical medicine, infectious disease, and also health system strengthening. So he currently serves as the adolescent health and child. He's currently serves as the child adolescent health technical officer lead and also AMR focal at the World Health Organization country office, where he supports the Ministry of Health in developing and implementing evidence-based policies and strategies to improve health outcomes. Dr. Kamara holds a Bachelor of Medicine and Bachelor of Surgery from the College of Medicine and Allied Health Sciences, and also a Master of Science in International Public Health and Postgraduate Diploma in Tropical Medicine and Hygiene from the Liverpool School of Tropical Medicine, as well as a Master of Science in Clinical Trials from the University of Oxford. This person, our bookman, is currently pursuing his PhD. I will stop there and not go talk about. But he has played a key role in Sierra Leone's response, especially to the Ebola outbreak, the COVID-19 outbreak, and is widely recognized for his contributions to antimicrobial resistance, infection prevention and control, operational research, and that is the SOTIT, and also child and adolescent health. Our speaker is a prolific and committed leader in translating research into policy and practice, strengthening health systems, and mentoring the young generation of public health professionals in Sierra Leone, in which I'm his mentee and which I'm grateful for. And he's somebody that has done extensively in mentoring some of us. So, ladies and gentlemen, our next speaker to speak on from survival to practice in terms of the role of pharmacists in antimicrobial stewardship is no other person but Dr. Ibrahim Franklyn Kamara. Please put your hands together for him, as today they are not before them, but put your hands together for our next speaker. Yes, sir.
Yeah, thank you very much, Ivan, for that introduction. And thank you very much to the leadership for inviting me to this AGM. I think it is critical. And even though it's a Saturday, I've been following from the keynote address from Dr. Batima to Abob to Brahima, and then surely. So I think I'm in the right place. I'll say I'm in the spectrum that I need to be, because it is something I've been pushing for pharmacists to take the role in antimicrobial stewardship. So for us to achieve our 300 days, I call it a vision. We actually need to have medications on site. And not only having the medications on site, we need to have high quality medication, not falsified substandard. And even when these medications are on site and they're of high quality, they need to prescribe them appropriately. And our patients need to see how best this medication can be utilized as prescribed. So I will not labor much about the title, because we all know the title, we've seen the agenda. So, Ivan, go to the next slide, please. This is the start take-home message that AMR knows no boundary. And it's not a respecter of person, whether you're a medical doctor, a pharmacist, a lab scientist, or a nurse, every one of us are at risk. And today, in this AGM, all of us are at risk of suffering from resistant infection tomorrow. So it's a call to action for all of us to see how best we can ensure rational use of antibiotics, not only for the patients, for us to reduce preventable maternal mortality or preventable child mortality, but for us to be safe. Next slide. This will be the format of my presentation. Just give a brief background of AMR and then talk about global and national picture, and then what is antimicrobial stewardship, and then the roles of pharmacists in antimicrobial stewardship, and then the take-home messages. Next slide. So I guess people are actually okay with what AMR is all about. So I will not labor to talk much, but we just need to know that it's a global public health concern that has been identified by WHO since 2015, when our first global action plan was developed. Now we have the second global action plan, which runs from 2026 to 2036. So I'll advise my colleagues to have a copy of this global action plan, because it provides a framework on how all of us, pharmacists, doctors, public health professionals, can combat AMR in our region. And then, yes, even though AMR is, as it can happen naturally, but most of the problems we are facing presently is as a result of human factor. And when people suffer from resistance infection, actually hospital stay will increase, it will increase cost, and it will also increase mortality. And the fear, because of other crises like climate change, funding cuts, and then poor infection prevention and control, there is high tendency that the AMR burden is going to increase in Sierra Leone and other parts of the world. Next slide. So this is the global picture, because when we say something is a global public health concern, we need to
Yeah, Dr. Kamara, could you please check your internet? I think it's breaking. Dr. Kamara, are
figure
you?
because of, yes, can you hear me?
Yes, your internet was breaking for a moment. You can go on, please.
Okay, so I think I stopped around where the women and children, or the figure.
The figure, please.
Okay, so as I said, for us to say something is a global public health concern, we need to ascribe figure to it. So in 2019 alone, about 1.3 million deaths were directly as a result of AMR, and about 5 million deaths were associated to AMR, even though everybody is at risk of AMR, but women and children are at increased risk. So that's why it is good that the young pharmacists selected a theme wherein from principle to practice, because we know if we want to achieve the 300 days goal, we must use antimicrobial agents properly. And then there are several factors that are responsible for the AMR problem we are experiencing today, but inappropriate use of antimicrobial agents at the facility and also in the community is a huge factor, followed by infection prevention and control and poor vaccination coverage. Next slide. So this is the national picture. Most of the time when I tell people that AMR is a problem in Sierra Leone, they tend to ask question, how? And then I try to give figure to the problem. So in 2021, if we can see, we had 1,600 deaths directly because of AMR, and then about 8,000 deaths were associated to AMR. To be honest, these deaths that are directly related to AMR is even higher than the maternal mortality, because on a normal day, we expect to have, let's say, between 1,000 to 1,500 maternal deaths per year. So this tells us that we need to give attention also to AMR. And then the largest mortality for AMR was seen among under 5 children. And it's not a secret. Ivan, Noah, Abubakar, and others that have been involved in antimicrobial stewardship program can confirm that there is high usage of antimicrobials in healthcare facilities in Sierra Leone. When I say healthcare facilities in Sierra Leone, from primary, secondary, and tertiary, from public and private faith-based, high usage of antibiotics. In fact, most of the time, WHO has a threshold, will say about 50% of antibiotics that are used in healthcare facility on a normal day should not be used. Next slide. This is just one of the studies that I led when we did a national point prevalence survey of antibiotic use in 28 hospitals in Sierra Leone. The prevalence was over 70%. So that tells us out of every 10 patients, 7 that were admitted received antibiotics. And these are the top 10 antibiotics that were prescribed: metronidazole, ceftriaxone, ampicillin, and gentamicin. And then Cipro is also part of it. And as a healthcare worker, we need to know studies have shown not only in Sierra Leone, but also in the sub-region that there is high resistance to ceftriaxone and ciprofloxacin. So our over-reliance on ceftriaxone and ciprofloxacin should change, because we've seen a lot of high resistance pattern to common pathogen. And when we do what is called the aware categorization, the good thing, by then we were using the 60% threshold. So it was appropriate. It was 67% of the medication that were prescribed were from the access group of drugs. And when we label drugs to be access, these are drugs that are used to treat common condition, and drugs that are not prone to resistance, and drugs that are not expensive, and drugs that don't have high level of toxicity, and drugs that should be part of the essential medicine list for any country. So it was 67%, which was good by then, but now, because of the commitment from global leaders, the threshold for access has been increased to 70%, that all medication prescribed at a national level, 70% should be accessed. So if we're going to use the present target, then we are lagging behind. Next slide. So this is the most critical part. Van Breimer started talking about it. Dr. Batima also actually mentioned some of the components. So this is the reason why I always mention to colleagues that for me, when I say antimicrobial stewardship, it should be the anchor of the pharmacy department. So we mentioned the 5 R's, but I'm not going to use the R's. I'll try to just do the principles. So we're talking about the diagnosis, the drug of choice, the dosage, the duration, and then the escalation. But for us to know, for us to have a common agreement, so when we talk about antimicrobial stewardship, these are the systematic, coordinated approaches, intervention, initiatives that are designed to optimize the use of antimicrobial agents so that they can be effective for the longest time. And the core principles behind these are the 5 these that I've listed. And I decided to highlight 3 areas. If we want to quantify, if out of 5 areas, 3 areas are actually the responsibility of a pharmacist or a pharmacy technician or anyone that is interested in pharmacy: the drug of choice, the dosage, and the duration. Because of time, I will just try to just mention as an example. I can prescribe a particular medication for a particular condition. That medication might not be available in the pharmacy department by then. On a normal day, the pharmacist should give me an alternative that is effective in managing that condition using the standard treatment guideline, using the resistance pattern in that facility, or using the resistance pattern in the country. And then I might prescribe a medication, and then I'll document the wrong dosage. On a normal day, a pharmacist should pick up that prescription and mention that, Ibrahim, this dosage is not the appropriate dose. You need to give the appropriate dose of this medication, looking at the minimum inhibitory concentration of the drug, and then I will change the dosage of the medication. And then also the duration. I've decided to omit the route because most of the time it's binary. It's either oral or IV most of the time. So I decided to omit it. But the duration, I might prescribe a medication that should be prescribed as TDS and then I prescribe it as BD. The pharmacist should tell me that no, this medication should be prescribed TDS, not BD. So based on this, it is clear that if pharmacists are not involved in antimicrobial stewardship, we're not going to have rational use of antimicrobial agents in the hospital. We're not going to win the fight against AMR. So this is a clarion call on all pharmacists that are attending this AGM today to take interest in antimicrobial stewardship. Next slide. So just so we know, it's not going to be an easy fight. It's not going to be a quick win. It's going to take time because it involves behavioral change. Imagine I'm a right-handed person. I've been using my right hand as my dominant hand for the last 20, 30, 40 years. And then now you come and you start telling me, no, Ibrahim, stop using your right hand, start using your left hand. We are going to fight. We are going to argue. So prescribers, people that administer medication, people that dispensing medication have been doing, I'll not say the wrong thing, but we have not been doing the right thing for our patients. So it's a behavioral change when we talk about antimicrobial stewardship is going to take time, so we have to keep that in mind. And the ultimate goal of antimicrobial stewardship is to improve the quality of care we provide to our patients so that we can have good health outcomes and also we can save lives and then reduce healthcare costs. So this is why antimicrobial stewardship align with the 300 days of activism, wherein we want to reduce preventable maternal mortality, and we also want to reduce preventable under 5 mortality. So we can use this framework when we want to implement our antimicrobial stewardship in our healthcare facilities. The slides are with Ivan. They'll be provided after the presentation, so we don't need to bother to write or to screenshot. The slides will be available. Next slide. So now, what is our role as pharmacists when it comes to antimicrobial stewardship program? Young pharmacists should actually participate in national AMS intervention. So when Ibrahim was making a statement, I can relate to what he was position the pharmacy professionals to be. I've always said when I interact with Ivan and Noah, I always tell them we need to do more. As you can have people to specialize in clinical pharmacy, you can have people to specialize in infectious disease pharmacy, you can have people to specialize in oncology pharmacy. It's so diverse. So we should not only focus on hospital pharmacy, we should also be at the national stage. And one of the good things I'm happy about, the national AMR focal point is a pharmacist. But honestly, if I have to be black and white, I think pharmacists, we need to take the main stage when it comes to national AMS intervention. We need to come on board. And then for hospital initiative, young pharmacists should co-lead hospital antimicrobial stewardship program. I was very keen on this when I was developing the terms of reference for the AMS team and also the Integrated Health Facility Committee. I said we cannot have a single entity. We cannot say the AMS team should only be led by infectious disease doctor or a medical doctor, because in other parts of the world, most of the time, they tend to follow that approach. I said the AMS team should be co-lead a doctor or a clinician and then the pharmacist. This is the only way it can be sustainable. And also, young pharmacists should be member of the hospital AMS team. The fourth point is very critical. We should not be the point of only dispensing medication. And Van Breimer clearly mentioned this. We are at the center of the healthcare system. We should ensure we review the prescription of prescribers. I've done some minimal audits. If you look at this prescription, there are several errors, and we don't do it as a blame game approach because it's possible that the workload is high. It's possible that the standard treatment guidelines are not readily available. It's possible because of personal or other reasons that we make mistakes in prescribing. So if we have a good system together with the pharmacist, this can be corrected. So pharmacists should actually be involved in the review of prescription to ensure that the right drug, the right dosage, the right duration, and the right route is being adhered to. And then the fifth point, pharmacists should advise clinician on antimicrobial selection. I think I've explained this earlier on. Next slide. We are close to the end. Next slide, Ivan.
Arsenal, next slide.
Yes, okay, this is fine. It's fine. No, go back. Go back, please. Okay, yes, this is fine. Yeah, so pharmacists should train healthcare providers and also patients on rational use principle and also IPC. So I decided to include IPC. This is also a critical component that pharmacists need to come on board. If I can give an example, the National IPC program, they have a pharmacist, Ralph Williams, who has been very strategic when WHO was even supporting the production of local alcohol-based anaerob. And this is one of the success stories that most of the time, when we talk about local sovereignty and all the rest, we'll say Sierra Leone, we are producing alcohol-based anaerob. So you definitely need a pharmacist for some of these processes to continue. So this is something that pharmacists should take interest in to pursue further education in IPC so that they can be strategic. Pharmacists should also be interested and responsible for monitoring of antimicrobial consumption and use, and also resistance, and report the data to the Integrated Health Facility Committee and the national level. When Shole was presenting about M supply, I was very jittery to say M supply. I've been to several facilities in Sierra Leone. I don't think the M supply system is working effectively. And when I interacted with my colleagues pharmacists, they would tell me because of the workload, we have not been filling this platform properly. I think it's only in Kono that the M supply system is working. I asked why. I was told they employed a dedicated person to be doing this process. So irrespective of the challenges, as pharmacists, we need to be keen on monitoring antimicrobial consumption and use wherever we work in our facilities and in our program. Pharmacists should also lead and participate in the development of AMS policies and strategies. Pharmacists should also collaborate with infection prevention and control team for the effective implementation of IPC to reduce healthcare-associated infection and then improve IPC practices. And then the last point, if you know me, you know this last point is my heartbeat. Wherein I don't know why as Sierra Leoneans we're not interested in research, but I'm advising my young pharmacy colleagues, please take interest in research. There are lots and lots of benefits as Sierra Leoneans we are missing out. I always tell people we should not allow foreigners or external people to write our story. We need to write our own story. Research is a continuous learning process. Research will open funding opportunity. Research will open training opportunity. Research will open postgraduate opportunity. Noah will not want me to mention this, but I will tell you Noah is a testament of what research can do now. When he's doing his master's program, he can call me and tell me, Ibrahim, some of the things that have been taught presently, I know them already. So please let us take interest in research. Moreover, research in AMS, research in IPC, research in adverse drug reaction, research in supply chain, research in cold chain management. Next slide, final slide. I always say I like my take-home message because I try to make them to be very simple and to the point. So I believe, as all other healthcare workers, young pharmacists play a critical role when it comes to national and hospital AMS initiative. Without pharmacists on board, we are not going to win the fight against antimicrobial resistance, and we are not going to ensure rational use of antimicrobials in our healthcare facility. Young pharmacists should co-lead hospital antimicrobial stewardship program. If you want to know more about this, you can reach out to me. Then we can see how best we can work together, because we are planning to establish antimicrobial stewardship in all the tertiary. I think we have 3 tertiary hospitals in Freetown, and also the regional hospitals, and then hospitals that have microbiology capacity. And then young pharmacists should pursue a training in AMS and IPC to increase the community of practice. As I said earlier on, this is something we need to take with keen interest. I always say learning should be a lifelong journey. We should not stop. Even when you have PhD, you go for more. You can have 2, 3 PhDs. Learning should be a continuous process. And AMR, AMS, I think they are new, and a lot of people don't have expertise in it presently. So if we take interest in it, we'll always have better job opportunities and also academic opportunities. Young pharmacists should lead AMS awareness and training initiative, including WOW. Also, I think Fam Brian Malai also mentioned this about community awareness, community campaigns, and community engagements. I think people like Buya, Ivan, Noah, Abubakar, they have been utilizing these spaces. They have been communicating on several issues. I think we need more people to come on board when it comes to advocacy and community awareness on rational use of antimicrobial. And then the final point, but not the least, young pharmacists should be involved in the conduct of research in AMS and IPC. Thank you, Anova.
Wow, wow. Thank you very much, Dr. Kamara, for your presentation. Thank you very, very much. Y'all go like be reacting. You can put it on the chat box. Dr. Kamara, um, I'm almost tempted to call you DNA, but this is a professional space. Yeah, thank you very much. It has been an amazing presentation. We've learned a lot. So as the moderator of this session, the second session also, we go through what we did for the first session, wherein you put a QA on the chat box to see if you want to ask a question. You can equally raise your hand if you want to. Please may the question be guided to what he spoke about during his presentation, and you can ask other questions, but we only have 5 minutes for question. Over to you guys. I don't know if Noah and Ivan, that have been close mentee to Dr. Kamara, want to say a word or two before we go to question. But
Yes.
I'm really impressed with the presentation thus far. Dr. Kamara and I goes way, 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 way back during the Ebola outbreak and the Ebola fight. I know he's a passionate public health expert. Um,
Yes. So
he
for the
he used to be me bra, but now not like we. I don't this bra. I don't this bra. I
I
don't.
know.
It's
So for
okay.
the while we wait for the questions to come in, please let's use the same pattern. If you want to ask a question, just type QA in the chat box, and then Fodi will note those that want to ask question. While we wait for the question, I want to use the moment to recognize the presence of Dr. Mohamed Bao, our dean, former dean, but he's still our father. Like, he's been our mentor. He's with us right through from pre-farm to here, over 10 years with us, and he's here with us again today. Dr. Bao, we want to recognize your presence, and I don't know whether you have something to say, maybe a minute,
Yeah, yeah, yes.
maybe a minute, Dr. Bao.
I know Dr. Bao is currently proud seeing all of us.
Yes, that's why I want to hear
The
his
speech
voice.
grammar, like say, like Dr. Bao, over to you on behalf of YPG. We really appreciate you. So I don't know if you can unmute your mic and say a word or two.
Yeah, good day. Hello.
Yeah,
Yes,
we
we
can
can
hear
hear
you,
you,
sir.
sir.
Yeah, thank you very much. I'm so happy that this AGM is going on like this. I want to say thanks to all the speakers, and I want to apologize for really joining the discussion late. I was in another meeting with the act, the two acts we are working on it as stakeholders. So I just came from there and decided to join the meeting. So thank you so much. I really appreciate this recognition. I remain to be a pharmacist, and I have mentored quite a good number of you guys, and I continue to do that. A few days ago, I was with um, um, Ivan. Ivan almost always, most cases, go to my office, and we discuss a lot of things in terms of professional development and career development. So, like Dr. Kamara rightly said, there are no limitation to education. You can seek to whatever level you may want. You can have double PhDs and the like. So don't say I have this, so I'm not going to seek for another one. So I continue to advise colleagues. The sky is our limit. You can go further than ever. Don't rely on just first degree and sit down. Go ahead. I'm proud of Ture, Noah, and all of you guys out there, and continue to make us proud as Sierra Leoneans. I've had a lot of engagement with some other leadership beyond the university, and had a lot of discussion with other colleagues about you guys. And I'm very proud of you. So continue to make us proud out there. And some of our colleagues may join you very soon, if they have not already gone. We continue to enlarge our horizons, and the sky should be our limit. So thank you and congratulations for your AGM, and I continue to monitor the process. Thank you very much. Over to you.
Thank you so much, Dr. Bao. It's such a thoughtful word from you. You've been our father. You've been with us like since we were in inaugural class of the pre-farm, and it was, of course, you are part of the team that brought that idea, and you should be proud that that particular cohort created a serious paradigm shift when it comes to pharmacy practice, and you are central to it. Thank you so much for that, and we continue to be so indebted in your mentorship. We also have Dr. I think, I don't know whether he's still here. Let me just hang on, please. Let me check the chat box. Please be, if you have a question, be typing there.
I
Or you
think we used to have the deputy pharmacist. He
Yes,
was with us.
yes, I was looking for him. Oh, okay.
Um,
But when I'm sure he will be back, we'll try to
yeah.
acknowledge. And then we also have Dr. Adama Tui. She's a very supportive person. I can remember I shared some of these vision with her when she used to visit us at Oladurin. And she has always been there in terms of pharmacy and advancing pharmacy. Dr. Adama Tui, if you're there, you can just say hello so that we know that you're around before we move on to the Q&A. Okay, probably, okay, but I'm sure she can hear us. So, Fodi, over to you. If you have the questions, let's move on to the Q&A because we don't have time.
Yeah. So before we move on to the Q&A, I think since we're still in the realm of recognition, I know my like the YPG past ESCO and everybody that has been recognized. So I just know if you've not been recognized, don't know, we are not cherry picking. So Farm Jimmy, Farm Bremalai, and all past ESCOs, you're highly recognized, including past executive member of NAPSSLs. Though this is not NAPSSL event, you're also equally recognized. All the previous presidents and ESCO members in NAPS, you're highly recognized. FAM, John Smith, of YPG, NAPS-SL, of SLMDA, of all the organization,
Business
including
association.
business association, including that school with the issue of running codes. They are highly recognized.
Let's go to the Q&A, please.
Yes. So let's
You
go
are
to
fired.
You won't win this fight. Please, let's go to the Q&A.
so let's go to the Q&A. So our first question.
Before we go to the Q&A, please don't forget to sign in your attendance. The link is in the message chat. Please make sure you sign your attendance. Please, I'm sharing the link again. Please make sure you sign in your attendance. And if possible, before we go to the next section, we will want to have the group pictures at the end of before we go to the AGM. So if possible, if you can change your video background to the YPG flyer that I sent in the group, please make sure you do that so we can have a very, very good picture as we are taking the group pictures. So please take note of that before we start the
All right,
Q&A.
thank you very much, Ivan. So I don't know, Buya, you want to ask first and then you want to ask last. So let's go to the first one and then we ignore the last one. So we go to Pharmacist Buya. After that, we go to Honorable Farm John Smith.
Thank you, Dr. Kamara, and thank you for the team for this session in particular. For me, addressing AMR is very important that we look at intentional investment. So I wanted to, number one, draw maybe a few thoughts on Dr. Kamara to say a few things on why do we need to really get intentional investment in the fight towards having a world-free AMR. And then the last one is on grant opportunities for research. He underscored also the need for research generation, maybe that regional or global level, or maybe start from at national level. Do we have sight of possible opportunities leveraging on research for data and decision making, even that would go especially for policy formulation among others? Thank you, sir, and over.
So thank you very much, Buya, for the question. So I like the political line that you mentioned, intentional investment. And as I said earlier on, one of the key factors that will increase AMR in Sierra Leone and even outside of Sierra Leone is the funding cuts. Because if you take, for example, for you to do culture and susceptibility, on a normal day when we did the cost analysis, it's around $22 that somebody should pay. And luckily, we've established labs in Sierra Leone, the bacteriology lab, which was over close to $3 million, which is very expensive to have this capacity. So definitely we need innovative financing, but it's not only for AMR, other areas will also compete for this innovative financing, talking about taxation on what, let's see if there is a percentage of GST that will go to healthcare. And then when it goes to healthcare, a percentage that will go to improve AMR services and facility. It's going to be complex, but always what I tell people, for me, at times, it's not about the money. People like Ivan and Noah and Abaka, when they work with me, I always tell them, let's forget about the money. Let us focus on the initiative. Let us document what we want to do. After documenting what we want to do, then we can do resource mobilization. Take, for example, if we come together as a group and then do a nice proposal, I want to talk about rational use of antimicrobial, more specifically antibiotics among young people in Sierra Leone, and present this beautiful proposal to AfriCell, to Orange and other agencies, telling them about the perceived benefits that they are going to get as a tele-provider service in Sierra Leone. And then the benefits these adolescents and young people have, and then the benefit the country will have. Definitely, I think we can get some funding to do our initiative. Irrespective of that, we need to do advocacy. That's something also I was planning to put on the slide, but because of time, I cannot. So we are talking about now advocacy when it comes to resource mobilization. We need to put a face to the mortality of AMR. Now that we are talking about 300 days of activism, we can push Shirley, we can push Dr. Moses, how much of the resources you've allocated for antimicrobial stewardship initiative. We do advocacy, but to be honest, The funding is not there. So we need to see how best we can do advocacy and do innovative resource mobilization. And then you mentioned research. If they are platform in Sierra Leone, I would say Sierra Leone, when it comes to research, you can do 1001 research, because the research capacity or the research landscape is very thin. But again, the same thing I will always say, we don't put money in front. I'll give you an example. Presently, I'm doing a nationwide study on knowledge, attitude, and practice on antimicrobial stewardship and antibiotic use in all 16 districts in the hospital. And I'll tell you, I don't have 1,000 leons for data collection. You know what I've done? I've utilized my network, like Ivan as an example. He has collected data at Oladurin and then at PCMH because he works there. And then he's going to collect data at Wokupa. I have a young doctor, I think he's also part of this call, Suluku. He has collected data, I think, in 5 or 6 facilities in Western area. So imagine if I want to quantify the cost for this data collection, I'll tell you it will be very huge. If I ask Ivan to leave Freetown and go to McKinney, I have to give him vehicle, fuel, DSA for Ivan, DSA for the driver. I don't have that money, but I want to generate evidence from Sierra Leone that other countries can learn from when it comes to antimicrobial stewardship and antibiotic use. So let us be innovative. We have our colleagues in the district. We can develop a proposal, a small research concept, and share with the district pharmacists and talk to them and for them to help us to collect data. And then we publish as a team. It will be a win-win. So we can do research. And Ivan, Noah, Abubakar, I think they have a lot of research ideas that they can share with the group. And then we can see how best we can champion that research. And definitely I'm willing to support in the arm of research. But we can have a one-to-one conversation on this, and then we can see how best we can move the agenda forward. Thank you.
Thank you very much, Dr. Kamara, for that response. So now we go to Farm Smith. Farm Smith.
Yeah, thank you so much for it. Thank you, everybody. And thank you, Dr. Ibrahim Franklyn Kamara, for that. In your presentations, you mentioned the 5 Ds and you highlighted the dose, the duration, and then I see you left out the diagnosis. So my concern is, what can we do to leverage on diagnosis? We are in work in a facility where you have multiple diagnoses of disease conditions, and wherein probably you still have challenge with the lab, and you have policy document, yet you want to implement that document for them to manage that. But we see more of empirical treatment being prevalent across the health facility in Sierra Leone. So what do you think we can do with diagnosis? In the government document, we are seeing provisional diagnosis, we are seeing final diagnosis, but yet we keep having sometimes even query diagnosis. You have a child that will be on a particular antibiotic for a long time, duration, sometimes it's open prescriptions. So looking at it at that point, what can you advise? Because pharmacy, you'll be at the free healthcare dispensary, we'll pick up this challenge and we'll communicate that this child has been on this zone for long. Can you stop it? And sometimes they will tell you, we're still waiting on labs, or lab has not given the result that it takes. Do you think it's feasible for us to tackle it from that point and you not highlighting the diagnosis, which is the specific role of the medical doctor? Over to you. Thank you.
Yes, thank you, Farm Smith, for that interesting question. I mentioned earlier on that I deliberately highlighted the 3 components you mentioned: the drug of choice, the dosage, and the duration, and I explained all of these 3 components, how it directly related to our role as pharmacists. And because, as I said, I know the diagnosis component lies with the prescribers. In fact, I will not say doctors alone, because in some settings, in like the primary health level, you have nurses and midwives that are prescribing. You have CHO and CHO that are prescribing. So nowadays, I try to move from just saying doctors to clinicians or prescribers. So yes, I deliberately did not identify because I know it's not within our remit, but you rightly identify a very important component that we need diagnostic capacity to do targeted treatment. And I'm also now pushing a global campaign. I think together with 209 other researchers, we are doing a global piece on antimicrobial stewardship, wherein we should not over-rely on diagnostic because, as I mentioned, the cost for you to establish a bacteriology unit is very expensive. As I said, for those 3 labs, I think we spend well over $3 million. Where are we going to get this money to put these labs in all of the district hospitals, in PHUs in Sierra Leone? We have over close to 2,000 healthcare facilities, including PHUs. It's not realistic. It's not possible. So what should we do whilst we wait for us to improve our diagnostic? And that is our goal. I will tell you, even the empiric treatment, people don't follow the standard treatment guideline. Again, I mentioned this in the free healthcare quantification meeting. I have never been to any facility in Sierra Leone and I've seen the standard treatment guideline. It's not there. And then I was told that, oh, they can use the app. I said, let's be honest, how many people want to use their phone to double check their medication? They're not going to do it. They don't have time. But if the hard copies, they are most likely they will be pushed. A nurse can send a reminder to the prescriber and say, you need to check. So that's also something we need to push as YPG to see how best we can advocate at minimum all these healthcare facilities in strategic ward should have the standard treatment guideline. We also improve IPC. When you prevent infection, you prevent the use of antimicrobial agent. That's why I said the pharmacists should also be involved in IPC. So yes, Smith, I agreed. We are all pushing. We need diagnosis and all the rest, but we have to know it's expensive. Notwithstanding that, other simple diagnostic tests can also help us. If we do RDT for malaria and it's positive, there is no reason for us to give antibiotics. We give anti-malaria. If you do other blood parameters, you notice a high white blood cell level. It tells you that there's a bacterial infection going on. Then you can feel safe to give antibiotics. And in some other parts of the world now, they are using C-reactive protein to guide the selection of antimicrobial, to use antibiotics or not to use antibiotics. So I think the diagnostic is not only a problem for antimicrobial stewardship, but for all other processes in Sierra Leone, mainly maternal and child health condition. But we can also discuss this personally to see how best we can use diagnostic stewardship to improve antimicrobial stewardship, but we should not over-rely on diagnostic stewardship alone. Thank you.
Wow, this is very, 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 very good. It sounds so knowledgeable. Thank you very much, Dr. Ibrahim Franklyn Kamara. On behalf of YPG-SL, I want to extend gratitude to you, and we really appreciate what you've done in terms of mentorship provision, accord that you've extended to pharmacists and pharmacy students across our profession. We don't treat your impact lightly. We really, really appreciate you because we're seeing a testament of what you've done and what you're doing. We want to thank you for everything. We want to thank you for putting Mama Salon first in all you do. And God will richly bless you in all your endeavors as we continue. So I don't know if the leadership of YPG has something to say to Dr. Kamara before we move to the next point of our AGM. Over to you, Ivan and Noah.
Yeah, thank you so much, Fude, for moderating these 2 wonderful sessions. Thank you to Dr. Kamara as well as Famshole Beckley. I mean, your presentations were really, really insightful, and we really appreciate you taking time to grace our occasions and to grace our occasion rather, and not just grace it, but deliver 2 powerful presentations. We really, really appreciate you making time. It's Saturday, it's long, but you being here, it's really, really appreciative from our own part. Dr. Kamara has been a personal mentor to me and to many others. We always have our fights. In fact, I have to work for him currently, but I'm sure he knows the workload I have currently. This AGM, I have so many other things. He's always on my neck when it comes to delivering, but that is how it is. You just have to
Well, Love fraud, man, but the fraud incident. I don't can
Yeah,
fraud me.
yeah.
Don't fraud me.
Yeah, so thank you so much. Ivan, do you have anything to say before we what would happen is